so very much, Christy, for the kind introduction. I'm going to share my screen out here. I hope it's visible.
Yes.
All right. So, at the outset, good evening to one and all, respected teachers, mentors, friends, and colleagues. I thank AIOS and OPI for this opportunity and the kind invitation to be part of it. And I'm humbled and overwhelmed being part of, this particular symposia, international symposia, amongst the stalwarts in retinoblastoma. And thank you once again. So I'm going to talk about something which is very important as far as retinoblastoma is concerned, especially in the low-income countries, and that is orbital retinoblastoma, where we find advanced tumors. So it is challenging, but then over the past many years, we have recognized and realized that we can save them too, and we will see what we are doing in 2021 with orbital retinoblastoma. I have no financial disclosures or interest, and I extend my gratitude towards the patients and parents and my mentors who are in this platform as well, and especially my team who have been, thick and thin together, including the pediatric oncologist, radiation oncologist, and everyone in the management of these children. So I'll just, take you through a few cases. So what are the major challenges that we face in this part of the world is that we get to see these advanced tumors which has come out outside the confines of the eyeball. So this was a child who was initially diagnosed to have bilateral retinoblastoma, where the parents deferred the chemotherapy when it was advised, and the grandparents thought that traditional medicine would help, and this child was on traditional medicine for 1 year. So there are certain social beliefs in this part of the country that actually is a major challenge for us, and it has still not changed. It has not changed in 2021 so far. Yet another case, this is a 13-year-old girl who presented to me. This was just a year back, and initially when she was 10-year-old, she was seen in a tertiary center with a retina specialist, where she was diagnosed to have traumatic cataract, subhyaloid hemorrhage, NVI, NVG, given treatment surgically as lens aspiration, past planar vitrectomy with multiple injection Avastin for the NVI, NVG. And then after a year, the child, presented in a regional medical college where she was found to have a staphyloma, where the eye was enucleated without, even having slightest of the clue that there could be an intraocular tumor. Enucleation was done. The pathology showed high-grade neuroendocrine carcinoma. The child was referred to another center for systemic chemotherapy, where they abandoned the treatment. So, this was how she presented. As you can see here, this is the implant which has been pushed, forward with an orbital tumor over here. In fact, we were thinking probably it could be an intraocular medulloepithelioma, a malignant variety, or a retinoblastoma, where, it has extended outside the confines of the eyeball. An incision biopsy was done, and then it was proven to be retinoblastoma. This is after 2 cycles of chemotherapy. So another challenge is clinical and pathological, misdiagnosis that sometimes we come across, especially in older children presenting with retinoblastoma, and patient counseling. The most important challenge in India, and I'm sure it's in Africa and South America, is the abandonment of treatment. And this is how these children land up with orbital retinoblastoma. As you've already seen, it's the extraocular extension of an intraocular retinoblastoma. Now, the prognosis of life salvage continues to be a concern in extraocular retinoblastoma, because this remains as the most important predisposing factor to tumor-related death. And in fact, the risk of systemic metastasis is as high as 10 times. And this is what the challenges that we face. Now, when we talk about challenges, I'm sure, Dr. Carol, Dr. Abramson, who, sees patient in the West, well, of course, the incidence is reported as less than 2%, but it's not the same. There is geographical variation in the presentation of retinoblastoma. And the main challenge in the low-income countries is the orbital retinoblastoma, where it is reported as high as 60%. Now, this is one paper that I recently picked up, and this is somewhere in Botswana where they had reported. And when we talk about retinoblastoma, we usually talk about leukocoria as the presenting feature. Well, in their paper, 54% of the patients presented with proptosis, and it was orbital retinoblastoma. So it is indeed a challenge. In fact, intraocular retinoblastoma grows bigger, occupying the globe, leading to a proptosis. Then it comes outside the confines of the eyeball to reach into the orbit, extend into the optic nerve, and even intracranial extension. And these are patients that we come across in our practice where it's so helpless once it has reached, a CNS metastasis and a CNS extension of the tumor. So in our practice, we classify it based on the presentation into primary, secondary, accidental, overt, and microscopic. Primarily, they present with an extraocular extension. Secondary, where there is an orbital recurrence after enucleation. Inadvertent intraocular procedures where there is accidental perforation. Overt, where you actually miss radiologically and clinically of an extraocular extension. It could be a smaller one. And then microscopic, anything which extends extrasclerally and into the optic nerve. And what do we do? This is exactly what we do in 2021. And this has been a practice all throughout. And Dr. Shantada has already, published the staging system of retinoblastoma, where a CSF analysis and bone marrow biopsy is done in order to stage it. So if it is just confined to the orbit, we call it orbital retinoblastoma. It could have a lymphatic metastasis also at that point of time to the regional lymph nodes. But once it is, there is a hematogenous or a CNS extension, then it goes to the stage 4. So now management of orbital retinoblastoma has been a challenge. From the conventional management, from these, publications and research which has been done, the mortality rate has been reported as high as 100%. Even with the combination of radiotherapy and adjuvant chemotherapy, it was found to be 70%. So our major concern as far as orbital retinoblastoma, where we see in low-income countries, is basically life salvage. So a multimodal treatment protocol with a judicious, implementation of sequential combination of chemotherapy, surgery, radiotherapy, it could prevent the systemic micrometastasis. And we have seen this in common cancers like breast cancer, GI cancers, and lung cancers, where there has been a multimodal treatment protocol which was proven to be, beneficial as far as improving the survival of these patients are concerned. So with the same backdrop, and I remember, this was something that was done when I was doing my fellowship with Dr. Santosh Unava, and we had, looked into all these cases who have undergone the intensive multimodal treatment protocol. So basis of our treatment protocol is that high dose chemotherapy in order to, prevent the systemic micrometastasis, enucleation for a surgical clearance. If at all there is a microscopic, surgical residual, the external beam radiotherapy takes care of it, and then we do a high dose chemotherapy of 12 cycles. So when we talk about high dose chemotherapy, it is the standard, it is the vincristine, etoposide, carboplatin, which is the time-tested chemotherapy protocol that we use for retinoblastoma, but we escalate the dose of the same protocol, and that's why we call it a high dose chemotherapy. And why is it so? Because we always know that, once it's inside the orbit and involving the orbital fat and the muscles, it's impossible to have a surgical clearance, even if you do an exentration. You might have a residual orbital disease, which cannot be taken care by systemic chemotherapy. You might have to give radiation locally to take care of these surgical, orbital residual. And well, external beam radiotherapy alone wouldn't take care of systemic micrometastasis or metastasis. So there need to be a sequential combination of all these treatment modalities. So we looked into, the 40 patients, which is classified under primary, secondary accidental overt and microscopic, of which 18 were primary. And then we found, when compared to other studies, the survival rate was very encouraging and promising, of 90% survival. So what did we do new in 2021? We again got a team of fellows who looked into the series, and we found that this was primarily done on primary orbital retinoblastoma. We had, multi-center additional cases, and we found that in 44 primary orbital retinoblastoma, at 82 months of median follow-up, we got 95%, 10-year survival under the survival analysis, and which has been very, very encouraging. So there was one case who had a systemic micrometastasis. So how do we go about it? I'm just going to take you through a few cases over here. Pre-treatment orbit, you can see the orbital extension, proptosis, 3 cycles of neoadjuvant chemotherapy. You can see the thysis bulbi over here, and it is at this point the child undergoes enucleation. Post-chemotherapy 3, in another case over here, you can see there is complete regression of the orbital component. When it's radiologically confirmed after the chemotherapy, that it's at that point of time that we go ahead and do the enucleation. I'm just going to show this video over here. So what I want to highlight here in this video is nothing but, we don't go for exenteration. We don't take out the orbital fat, even in an orbital retinoblastoma. It's the same case that I showed you before, where, she's undergoing enucleation after 3 cycles of high-dose chemotherapy after radiological confirmation of, orbital regression. So in fact, we don't even cut the muscles out. We preserve the muscles. In fact, some of the important steps that we take is, wherever the orbital extension was found initially in the radiology, the tenons is taken along with it, and some amount of orbital tissue is taken to prove whether it's negative or positive. And one of the most important things, since I'm an oculoplastic surgeon as well, is that we don't leave the socket without implant. We, in fact, after a removal of the eye, and we place the implant, and most important thing in the surgical removal of the eyeball would be to get a large optic nerve stump. So we go deep inside, we strum the optic nerve, even in a thusical eye, and we try to get a large optic nerve stump. So again, going back to what I said, an implant is even placed after the removal of a thusical eye in an orbital retinoblastoma, because we all know that this child is going to get radiotherapy. There is a high risk for contracted a socket where you may not be able to place a secondary implant later, and this patient is anyway going to get the radiotherapy. So these are the certain things that I would want to highlight over here. So in this particular case, the optic nerve length that we could retrieve was around 22 millimeter, and she had a negative optic disc margin. Post enucleation, radiotherapy, and the child is doing good. So as in the second case that I showed earlier, secondary orbital retinoblastoma, we don't even take the implant out. It's kept in place, treatment is completed, and this is how the child is. Optic nerve extension, again, up to the orbital apex. In fact, we had to give 9 cycles in this particular case for radiological evidence of regression of the optic nerve extension, and then enucleation was done, and the child is doing extremely well. So to conclude, the survival in patients with orbital retinoblastoma definitely improves with IMTP in our experience. So we chemoreduce, we confirm the reduction, we enucleate, we radiate, and we continue the chemotherapy. So this is what we are doing in 2021. We are able to save life in these children. Yet another child with orbital retinoblastoma was extremely happy with an artificial eyeball. Even after radiotherapy, he looks extremely well. So as far as research in orbital retinoblastoma is concerned, we have not done much from our side here, but then this is something which really I noticed recently, and we do have two of the authors over here, Dr. Shantada and Dr. Abramson, where they have found that, the recurrent somatic chromosomal abnormality in extraocular retinoblastoma, they found that the copy number alteration and the BCOR gene alteration is much, much higher in these patients. Well, I'm sure Dr. Shantada is going to discuss about, orbital retinoblastoma with me in the next 1 minute. So probably he might be able to tell us, how genetics can help us to predict, the aggressiveness of these tumors, even when it is intraocular, predict it, and well, how it could be applied in treatment in future. Thank you so much for your patient listening. And I'm very happy that most of our patients are doing well, no matter whether it's intraocular or extraocular. And thanks to all the parents for the support. Thank you so very much for the patient listening.